Welcome. My name is Del Kane. I am the founder and executive director of Advocates for Community Wellness. I want to personally thank you for joining us and our collaborating partner, the University of Chicago Comprehensive Cancer Center, for the October Cancer Awareness and Education Forum, They All Matter. This workshop is sponsored by an educational grant by NovaCure. The mission of Advocates for Community Wellness is to provide health promotion, disease prevention, and education to the public where people live, work, learn, play, and worship. And today, for most of you, we are delivering a message to you in your home. I would like to introduce our moderators for today's forum. Lynette Mahone, Community Engagement Director of Advocates for Community Wellness, and Aaliyah, Education Outreach Specialist with the University of Chicago Medicine. Lynette?
Welcome everyone, and thank you so much for taking time on this Saturday morning to be with us. We greatly appreciate it, and we look forward to presenting an array of information that we know will help you on your health and wellness journey. So real quick, I want to just go through the agenda. We will have a centering activity, which we'll do in a few minutes. Then we will have discussions that will focus on a lot of aspects of cancer awareness. Regina Hopkins will present They All Matter regarding cancer awareness and screenings. Then we'll have Ms. Hathaway present cancer genetics, and Ms. Chavez with cancer and nutrition, and then Ms. Kernet with clinical trials. We'll also be providing breakout rooms for you and having closing remarks. We are also going to do polls. So we ask that when we present a poll that everyone is actively engaged. What I want us to do is, because I know that we're all busy and things are hectic, a lot of things going on. So I would like for us to just get in a mindset for a moment where we're going to redirect our energy and be centered. At times, this might be a little bit challenging to do because you're always looking at your phones or the news, or the kids are running around when they're supposed to be focused on school. So what I would like is for us to put your phone upside down so you won't be encouraged to look at it while we do this. And I would like for you to close your eyes and think of something, whether it's a person, place, or thing that makes you smile. And I would just like for you to focus on what is it that just brings you joy. And I'm going to play a little music. And while you're doing that, let's close our eyes. Now take a deep breath in through your nose and blow it out through your mouth. Relax your shoulders. If you want to move your head in a circular fashion to just release that tension. Let's do a deep breath in. Blow it out. Another deep breath in. Blow it out. Okay, let's bring our mindset back to Opening our eyes, feeling good about our me time. Think about how beautiful today is and all the things that we're going to accomplish with our health and wellness. If you could just put your hands on your heart and just name one thing in your mind that you're very grateful for. And just prepare yourself for a health and wellness journey, because we already know for cancer, they all matter. And we're going to learn so much today and be able to share with others. Thank you. All right.
Thank you so much, Lynette, for that wonderful centering activity. Before we go on, I just want to briefly introduce myself. My name is Aaliyah Poulos. I am an education outreach specialist at the University of Chicago Comprehensive Cancer Center. I work in the Office of Community Engagement and Cancer Health Equity, and so we try to bring cancer education to communities that need it most, which is why we've partnered with Advocates for Community Wellness, because that's their whole mission and goal. So thank you all again for joining us today, and thank you to our speakers, all of our speakers today who are going to share some wonderful information with everyone. Okay, so as Lynette said, in between all of our speakers, we're going to have just a short poll for our participants, just to keep everyone engaged and see where we're at. So I'm going to launch our first poll here before we introduce our first speaker. Okay, so for the first question, the current recommended age to begin screening is 55. We had 100% of people say that that was false. The second question, I only need to get a mammogram if I feel or find something. That is false. If I don't have a family history, I don't have to worry about getting any cancer screenings. False.
That's false.
And there are many recommended cancer screenings. However, there's currently no recommended test or screening for lung cancer. And our response here was false.
Regina is up next, and she is our Director of Healthcation. And Regina is very well versed in the medical field. She is a family nurse practitioner. She devotes her knowledge to the South Side of Chicago. She has been practicing for over 14 years, and she definitely focuses on women's health, family medicine, acute care, and chronic diseases. Regina has taken her knowledge across the world. She's been to Bangkok, and she is also very in tune with mentoring, and she's also an author. So we welcome Regina, and we look forward to hearing what you can give us in terms of cancer awareness and screenings.
Thank you so much, Lynette. Welcome everyone for coming. Once again, I'm Regina Hopkins. I am the Director of Health Education for Advocates for Community Wellness. And today I'm going to be sharing just some information with you on the importance of knowing the different types of screening recommendations for various cancers. And also, as you're listening along, just to determine if you are up to date also with your cancer recommended screenings. We're also going to cover briefly some tips on risk factors, as well as things that could possibly or potentially lead to cancer. So the title of this discussion is called They All Matter: Increasing Cancer Awareness. And I want to point out that this particular topic is sponsored by Novocure. Novocure is a FDA-approved pharmaceutical company that has been designed to help fight cancer by developing the top treatments to help treat several types of cancers. Just in general, what is cancer? Cancer is the name given to a collection of related diseases. In all types of cancer, some of the body's cells begin to divide without stopping, and they spread to the surrounding tissues. So when cancer develops, what happens is the cells become more and more abnormal. Old and damaged cells survive when they should die off, and then new cells form when they're not needed. So pretty much it's just an overgrowth of bad cells that are just collecting and forming just this huge mass within the body. These extra cells begin to divide without stopping and may lead to growths called tumors. So in a nutshell, cancer is a bad cell that's begun to produce and multiply rapidly, producing this tumor that can eventually invade and take over the body. So just a few facts and stats. If you know anything about Advocates for Community Wellness, we do have a focus on the underserved community, primarily African American and Latinos. We know that these populations are the hardest hit when it comes to chronic diseases and also when it comes to certain cancers. So if we look at the African American population, we see that African Americans have the highest mortality rate of any racial or ethnic group for all cancers combined. In addition to that, the death rates for all the major causes of death are higher for African Americans than whites. This contributes to part of a lower life expectancy for both African American men and African American women. Another thing to note, some research studies show that about more than 200,000 new cancer cases and more than 73,000 cancer deaths were expected to occur only among African Americans in the year 2019. African Americans once again have the highest death rate and the shortest survival of any racial or ethnic group in the US when it comes to different cancers. When we talk about cancers, there's a lot of things that we know. We know some risk factors for some of them we don't know. Some cancers, they haven't discovered anything that leads to the development of certain cancers, but these are some potential risk factors, just general risk factors that we can look at that can lead to different types of cancer. One we know is age. As you get older, things happen in the body. So age is a potential risk factor. Alcohol, increased or chronic inflammation. And I want to point out inflammation, which is right directly across from obesity. Several studies have shown that obesity is linked to cancer. So many people ask, how is that possible? How do you determine, or why is it that if a person is obese, they have a high risk of cancer? So what happens is when the body has too much adipose tissue or fat cells, the fat cells begin to crowd spaces. And what happens is the crowding of the spaces in the body, if you have things just kind of pushing together, there's not adequate blood flow, not adequate oxygen being able to get in the body, it creates inflammation. And what inflammation does over time is when inflammation is in the body, it creates and changes the environment to make more cells become abnormal. So it changes the nature of the cell. So that's what inflammation does. It changes the cell's nature, which causes that cell to become a bad cell. And as we saw before, we read earlier in the previous slides, these bad cells just begin to multiply and rapidly increase, which leads to tumors. So that's the link between obesity and inflammation. Also diet, we're going to discuss a little bit further how diet affects increasing a person's cancer risk. Just to touch on diet very briefly, I have the health study here. I did see that there was an article done, research done in 1994 that they were trying to link hot dogs to cancers in kids, especially leukemias. And over the past 20 years, we've seen now that the American Cancer Association is now saying that diet does play a part in cancer, especially colon cancer. And they've linked the chemical nitrite, which is a preservative that's used in a lot of the processed meats. So your hot dogs, your sausages, your deli meats, they all have this chemical called nitrite, and it's used as a preservative. But they have linked this particular chemical to increase risk and development of colon cancer. So diet does play a part. We also have the environmental chemicals. There's a lot of things in the air that we aren't aware of that we're breathing and ingesting into our body that causes these changes to the cells. Exposure to radiation, also hormones. If you are immunocompromised, that can also lead to cancer. Sunlight, there's always a risk of skin cancer when you're exposed to too much sunlight because of the UV rays. Tobacco, of course, we know tobacco and smoking leads to lung cancer, as well as certain viruses. We have HPV, EBV, which is the Epstein-Barr virus, HIV, HSV, hepatitis. These viruses also lead to cancer. And if anyone's curious as to how, we know that what happens with a virus attacks healthy cells. It invades the body. So once again, going back to the previous slides, we talked about these healthy cells triggered by bad cells that changes the nature of the cell. So once the nature of the cell is changed and the cell becomes abnormal, we have this rapid production of abnormal cells that leads to cancer. So knowing your screenings, are you up to date? Although there's many types of cancer, we want to definitely focus on these 5 types. And we're going to go over some risk factors for each one and also the recommended screenings for each of these different cancers. We're going to discuss breast cancer. We're going to look at colon cancer, cervical cancer, lung cancer, and prostate cancer. And also keep in mind, I know we may have a wide age range individuals on today's discussion. And some of you may feel, well, cancer screenings are for the older adults, but knowledge is power. So you may not be at the recommended age now to receive the screening, but we do want you to be encouraged to take this information with you and even pass it along to family members that you may know, because eventually you will reach that age that you will need or be required to have these recommended screenings. So it's never too late to gain the necessary knowledge that you need to prevent something that could be prevented in the future. So breast cancer, what are some of the risk factors for breast cancer? So we see obesity. We talked earlier about how obesity creates inflammation and how the inflammation within the cells can change the nature of the cell. It's a risk factor for breast cancer. Alcohol, women who've never been pregnant, never breastfed, birth control pills, hormones within the birth control pill, especially that extra estrogen that birth control pills have. We know that estrogen is a component that can, when it's too much in the body, can lead to an overgrowth of cell tissue, especially in the breast, that can lead to cervical cancer. And hormonal therapy after menopause. You know, women, when they've gone through menopause, of course, you get those hot flashes. You need something to calm it down. Many gynecologists or specialists will recommend or encourage a hormonal supplement like estrogen. But keep in mind, many of them also will tell you that there are some side effects and some risks that comes with that. So hormonal therapy, the estrogen itself after menopause can lead to breast cancer. So when we look at the screenings for breast cancer, the screening for a mammogram to detect breast cancer starts at 40, but we encourage screenings actually in the form of a self-breast exam to start at age 21. So even though you're not around the age of 40, in your early 20s, I do encourage women to just start doing breast exams to get a feel of your breasts. You know, you want to see how your breasts feel on a routine basis. So that if you do develop or note any lumps or bumps or abnormalities, you want to make sure that you see your PCP right away to have it checked out. Once again, a mammogram screening starts at age 40. However, we know and we see that breast cancer is being detected in women earlier than the age of 40. Also, there's blood testing, genetic testing that can be done as well. And also there's ultrasounds too, although a woman may not be able to actually get a mammogram done before 40, but there are some ultrasound screenings that you can do to pick up different abnormalities within the breast tissue. Let's move along to colon cancer. Some of the risk factors we see for colon cancer, of course, age. Obesity is a common thread that we're going to be seeing amongst all the cancers. Family history, if you have a family person or someone in your family who's been diagnosed with colon cancer. If you're a smoker, once again, race plays a part. African Americans are at higher risk of colon cancer. And diet, you talked about those processed meats and foods that contain that chemical called nitrite that can lead to colon cancer. So if you're between the ages of 45 to 75, you qualify for screening for colon cancer. Now, the important thing to note here about the screenings, a couple of years ago, the screening for colon cancer actually started at age 50, but they've lowered the screening to 45 because they are now seeing more younger people developing colon cancer, which is pretty scary. So we went from age 50 to 45 now for the screening, the starting age for screening for colon cancer. And there's two typical ways that we can screen for colon cancer. One is called a fecal occult blood test, pretty much just a stool sample. You take a kit home, you put some poop on a piece of paper. There's a little wand that you dip it in, you send it back to the lab. It picks up traces of blood in the stool, okay? The next screening, which I call the gold standard, is the colonoscopy. This is the actual test where you have to go to the hospital. You know, there's a flexible little camera that goes into the colon and look for signs of colon cancer. A lot of people are fearful of the thought of getting a colonoscopy because, you know, no one wants anything put into any openings in their body. However, I do encourage all my patients, if you have the option to do the colonoscopy, please do that one, because the stool test only picks up blood in the stool. However, the colonoscopy can actually find those polyps that are abnormal growths in the colon that may be lying in the colon that the stool test can't find. With the colonoscopy, if you do have those polyps, most of the times those polyps are benign, but some of them do turn into cancer. But the good thing about the colonoscopy is those abnormal little growths or polyps can be removed during the procedure of the colonoscopy. So if you have that option to do the gold standard test, which I call, which is the colonoscopy, please opt to do that one. If not, you know, the next option is the stool kit, but just know that if you do the stool sample, if blood is found, you have to get the colonoscopy anyway. Okay, so next up we have cervical and endometrial cancer. Some of the risk factors for cervical cancer is HPV exposure. A lot of people don't have a lot of knowledge about HPV. HPV stands for human papillomavirus. It is an STD, you know, that's contracted during sex. And this virus will lead to cervical changes, cell changes in the cervix that will lead to cervical cancer. cancer. Okay, in addition to that, smoking, early sexual activity, weaken immune system. In addition to that, we also look at endometrial cancer. This is a cancer that's not commonly spoken about, but I have personally been seeing a lot of my older patients developing endometrial cancer. And what happens is the lining of the endometrium within the uterus becomes very thick. There is cells once again multiplied. And the common sign for endometrial cancer for women is having bleeding after they've had menopause. You've gone through menopause, you've gone more than a year without having a period, and here pops up some clotting. Common sign of endometrial cancer. If you do have that, please see your PCP to get the appropriate screening. The screening for endometrial cancer is pretty much a pelvic ultrasound followed by an endometrial biopsy. Cervical cancer screening, pap smears every 1 to 3 years, starting at the age 21. Prostate cancer is up next for all the men. I don't think we have any men on the call today, but if we don't, of course, every woman knows a man. Encourage the males in your life to get screened for prostate cancer. Risk factors, age, race, family history, diet low in folic acid. The screenings for prostate cancer is 40 and up, primarily for African Americans. Generally, the screening for prostate cancer starts at 50. If you have a family member with prostate cancer, screening goes down to age 40. Most of the population I work with are African Americans, so I screen all men 40 and up. And don't be afraid. Most men are also afraid of this test because it's a digital rectal exam in most cases. No one wants, once again, having something put in openings in their body. But there's a blood test also called a PSA, and it checks and screens for an antigen that's produced from prostate cancer. So it's a simple blood test for men to get at the age of 40 to screen for prostate cancer. Lung cancer. Risk factors for lung cancer: cigarette smoking, whether it's a cigar or a pipe. Secondhand smoke, if you have anyone smoking around you, despite you not being a smoker yourself, increases your chances of getting lung cancer. Family history, HIV infection, once we see those immunocompromised individuals. Environmental factors, also exposure to asbestos, radon, a polluted air. Screenings, there is a screening for lung cancer, believe it or not. Starting at the age of 55, if you have a history of smoking, you can get screened for lung cancer. It is a simple test. It's a low-dose CT scan that picks up any type of abnormalities or abnormal tissue or mass within the lungs. Also, if you're less than the age of 55, you can get a simple chest x-ray if you're having symptoms, which is persistent cough that lasts longer than 3 weeks, problems breathing, shortness of breath. Or once again, if you've had a history of smoking, you're under the age of 55, and you're having those symptoms. So we've talked about all the different types of screenings. We've talked about risk factors. How can I reduce my risk? First up, get the regular cancer screening test. We've gone over several recommended screenings. If you fit the category, please see your PCP to make sure that you've had those tests done. Regular screening tests can catch some of the cancers early when they're small and they have not spread, and these are easier to treat. Also, get to a healthy weight, exercise. We saw how obesity plays a very important role in development of certain cancers. Eating a healthy diet, organic or plant-based. We also talked about how certain foods have these chemicals in it that can lead to cancer. If you're a smoker, stop smoking, limit alcohol use, and also most importantly too, adequate vitamin D intake. There's been a lot of studies and talk now about vitamin D. Vitamin D plays a huge role in helping to boost your immune system. And also some studies are trying to say that vitamin D, if you have adequate levels, can also help to potentially decrease certain cancers. So once again, stay healthy, get the recommended screenings, make sure that you stay in contact with your PCP, get those regular checkups, exercise, and make sure that you also, once again, spread this information to your family and friends because knowledge is key. We don't want you to keep it to yourself, but we want everyone to be healthy, not just you.
We're going to transition to our next speaker who will be speaking about cancer genetics. We have Ms. Faye-Ann Hathaway here. She is a genetic counselor at the University of Chicago Medicine Cancer Risk and Prevention Clinic. And she'll be speaking today about cancer genetics and what you need to know about your cancer risk.
Hi, everyone. Thank you for having me and putting this together. This is incredibly important for our community. I'm a cancer genetic counselor. I specialize in all areas of cancer. So I see patients anywhere from breast, ovarian, prostate to mesothelioma, even some heme malignancies like leukemias and lymphomas. So traditionally, the way we discovered that there were genes involved that we were born with was through breast and ovarian cancer. But we've really expanded since I've been in the field, which has been about going on 17 years now. So we can offer a lot more than we used to. And so this is also important if you've only had genetic testing in the last 5 years. We've changed a lot of genetic testing in the last 5 years. So to begin with, I want to start by going over what is basic genetics. So you can see here, I'm going to show you with my mouse here too. This is a cell. In our cell, we have chromosomes, and on the chromosomes are the genes themselves. And the genes have their own spelling code. And the genes are what the instructions are for the cell to tell the cell what to do. So to kind of go over way back basic biology, this is a picture of our chromosomes, and we all carry 46 chromosomes. This particular picture is actually a female because it has 2 X's, but men will have 1 X and 1 Y. And that's pretty much the only difference between males and females as far as chromosomes go. So all cancer is genetic, as Regina had already eloquently explained to us. The way we acquire cancer is by having something happen at the genetic level of the cell. And so that cell then doesn't know what to do. And it starts to rapidly grow out of control. And so that's what cancer actually is. But not all cancer is actually hereditary in nature. And I'm going to get to the difference here. So to kind of show you a little bit about what the difference is, when we think about sporadic cancers, sporadic cancer, you start off with a normal cell and you acquire some damage, but that one damage in that genetic makeup isn't enough to actually lead to tumor. What ends up happening is you have a system in our body that actually protects us against cancer, and it comes and it tries to fix that error. And those are called DNA repair genes or tumor suppressor genes. But if that one error gets missed, then maybe it replicates. And so now you have maybe a second hit occur. And now your body tries to fix it again, and maybe it gets missed again. And the third time, now it's starting to rapidly grow out of control, and that's what a tumor forms. So there's lots of steps to this, and lots of steps where our body can actually start off and try to fix these errors, both through DNA repair genes and tumor suppressor genes. Moving over to hereditary cancer, basically in every cell of your body, you already start off with one of these errors. But it's very specific to different areas of the body. So although we carry all our genes in every cell of our body, they're not all expressed in every organ of our body. So it's very particular to what you're at risk for when you do genetic testing. So basically you start off with in every cell of your body with some of these changes. And what ends up happening is you acquire more and more changes. The error that it happens is actually in that correcting system of our body. It starts off in the tumor suppressor genes or in the DNA repair genes. So if you think about it, if you have a copy that's not functioning, because we get one copy from our moms and we get one copy from our dads, if you have a copy in your body that's not functioning already, well, then your ability to fight cancer is a little bit not as good as someone who actually does have both copies working. So moving on, there are 3 types of basic cancer types when we talk about genetics of cancer. We have this, what we call sporadic, environmental, familial, and then there's hereditary. Again, I focus on the hereditary types of cancer. I'm going to show you kind of pedigrees about what differences between all these. So to begin with, sporadic cancer makes up the majority of cancer. So these are 70% of all cancers are actually sporadic. It's usually due to the environment. So a lifelong smoker who gets lung cancer, that's typically a sporadic form of cancer. Moving over, this is what a family history. So this is kind of what I do in the clinic. So when we take a family history, you can see here all circles are females and all males are squares. If you have one family member who got breast cancer and she was diagnosed at the age of 60, that's considered more of a sporadic family because you can see here we're not seeing multiple generations of cancer, and it's usually a later age of onset for these environmental cancers. Familial cancer makes up about 18 to 20%. So although it's hard to discern some of these familial versus sporadic cancers, these are still not the hereditary type because it's both genes, and it's usually a polygenic risk and the environment that actually puts us at higher risk for cancer. But familial, to kind of show you what that would look like, is you have one generation of cancer in one family. So again, we're not seeing the multiple generations, and it's happening at a later age of onset. So this could be because of both multiple genes, so not just a single gene, but also the environment that they're concerned about. So they were all possibly exposed to the same thing throughout their life. These individuals, when we think about familial cancers, the next generation is still at higher risk for getting cancer. It's still good to know where you fit as far as on that pie chart, whether it's familial, hereditary, or sporadic, because although you might not know that there's something hereditary in the family, having just any family member diagnosed with a breast cancer, depending on where you're at in relation to that person, does put you at a little bit higher risk. And that goes for all cancers, whether that's colon or prostate, lung, because you do always share some genes and your environment together. This is where my specialty comes in. Hereditary cancer only makes up 5 to 10% of all cancers. And depending on the type of cancer, so for example, in ovarian cancer, that number can change up to 20%, as well as prostate cancer actually has about a 20% likelihood to be hereditary in nature. So it's very dependent on cancer type, but overall, when we think about all cancers, only 5 to 10% of cancers are hereditary in nature. This is what a family history looks like for hereditary cancers. So you have a young breast cancer diagnosis. You can even have a bilateral breast cancer diagnosis. And again, you can see the multiple generations of cancer. It's really important to also remember that we can inherit genes that cause breast cancer from our dads, just like we can inherit genes that cause prostate cancer from our moms. So just because there's a male-oriented cancer in a family doesn't mean it doesn't apply to you. So this is one thing to keep in mind. So what are some indications of a hereditary or an inherited cancer family? The biggest indication is an early age of diagnosis. Typically cancer is, as Regina explained, typically cancer happens at a later age. So after the age of 50 is when most cancers happen. 1 in 2 people will actually get some sort of cancer diagnosis throughout their lifetime, but that will usually happen after the age of 50. Whenever also you see somebody getting more than one diagnosis. So again, typically people will only get one cancer diagnosis over their lifetime, and it's sort of a one and done. So whenever you see someone with more than one cancer diagnosis, even if they're 2 common cancer diagnoses, we still get concerned that something hereditary might be going on, something possibly wrong with the system that's job is to protect us against cancer. And also bilateral cancers. So when we think about cancer, cancer doesn't just spread all over the paired organs. So for example, for breast cancer, just because you have breast cancer in your right breast doesn't necessarily mean that you should have breast cancer in your left breast. Same thing goes for kidney cancer. Just because you have it in the right kidney doesn't mean that you would suddenly get it in the left kidney. So when you do see it in paired organs, in both of the paired organs, it is a higher likely to be hereditary in nature, because those are actually 2 primary cancers. It's not that it just spread over to the other part of the organ. So then we also have multiple family members being affected. So again, if you have a family history, and it doesn't necessarily have to be the same cancers, but usually related cancers. So again, prostate and breast cancer can go together, and then colon cancer and uterine cancer, or even ovarian cancer, can also be linked to one another. We've also seen some kidney cancers be linked to melanoma. Melanoma and pancreatic actually can also go together. So many cancers can be related. And so it's important to meet with a specialist to figure out which ones are related and which ones are not. Then again, also if multiple generations are being affected, you don't need me to tell you, hey, by the way, mom, dad, grandma, daughter are all getting cancer. Well, then something seems to be going on. It's just whether we could figure out what's going on. And then this is key to rare cancers. So male breast cancer doesn't typically happen, happens less than 1% of the population. So when you see it, it automatically raises a red flag that something hereditary might be going on. Pancreatic cancer is also one of those rare cancers, although we hear a lot about it because a lot of new celebrities have been diagnosed with a pancreatic cancer, but it is typically actually a rare cancer. Ovarian cancer is also very rare. Only 1 to 2% of the population will get ovarian cancer. The more common cancers, as Regina kind of explained, are lung cancer, breast cancer, colon cancer, and prostate cancer. And then the clustering of certain cancers within a family. The reason why I have this Ashkenazi Jewish ancestry is mainly because we know a lot about the Ashkenazi Jewish relation to BRCA1 and BRCA2, but we're coming out with a lot more data that suggests that not only is the Ashkenazi Jewish ancestry put you at higher risk for having an inherited cancer, but there are other populations as well. There's little pockets throughout the world that show us that there's a higher likelihood. For example, in Argentina, there's a pocket of what we call Li-Fraumeni syndrome. So it's really important to know your ancestry, and it's in America, it's a little harder to discern, but it is important to try to figure out where our ancestors originally came from. So why does this matter? The biggest thing it matters is because we all obviously are at risk for getting cancer, but some of us are at higher risk. And so we need to change what screening is for individuals. So as Regina went over, screening for colon cancer, for example, just started to the age of 45. And actually screening for colon cancer, if you have a family history, might be 10 years younger than the youngest diagnosis in the family. So we've even seen 25-year-olds getting mammograms or getting colonoscopies based on genetic testing results. It's not 100% chance for disease, so that's really important to keep in mind. But we really do have strategies nowadays that we can offer risk stratification, risk management. We can increase your screening, and we can offer screening that the general population doesn't have. So for example, for breast cancer, if you're at higher risk, you can do a breast MRI instead of breast mammograms. So all of this is really important. Just to kind of go over what are we talking about as far as risk stratification. So general population risk to get breast cancer, for example, is around the 10 to 13% likelihood over their lifetime. There's some genes or even familial risk that puts you at a moderate risk, which could increase it from 20 to 30%. But these BRCA1 and BRCA2 genes can increase that risk all the way up to 70-75% risk. So we're talking much higher risks, and so we need to do screening a little bit more than the general population. Ovarian cancer, again, general population is very low, but once we get to the BRCA1 and BRCA2 risks, we're talking a very high risk of getting ovarian cancer. And really for ovarian cancer, there's no such thing as early detection. So it's really, really important to determine, are you at these high risks? And so therefore, maybe we should start talking about taking out the ovaries once you're done having children, even before menopause. BRCA specifically has a risk for men. They do have a male breast cancer risk and also a prostate cancer of up to 33%. So we start prostate screening in men with BRCA mutations as early as the age of 40. That same recommendation is meant, as Regina explained, is meant in the African-American population, because in the African-American population, prostate cancer is a little bit more common and has a higher incidence and a more aggressive disease. So we really want prostate screening to begin at the age of 40. The other thing is nowadays, not only are we trying to prevent the cancer, but treatment and surgery might change based on genetic test results. So it's important that even if you are diagnosed with cancer, you want to get genetic testing just to see what your surgical management. And genetic testing can also offer your family members either reduced risk, meaning maybe if mom carries a mutation that's causing her cancer, maybe her daughter didn't get it and she's not at higher risk. And so that would be really good news for them at that point. The test itself is pretty straightforward. You can either get your blood drawn, which is what I prefer, partly because there's less room for error. Whenever you spit in a tube, there's a higher likelihood or increased risk for error. We have more failure rates and we have to redraw the saliva samples. I just kind of wanted to go over a little bit about this Angelina effect. A lot of women back in 2013, when Angelina was discovered to have a BRCA1 and 2 mutation, she went off and she actually removed both her breasts and ovaries. And since that time, though, there's been a lot of change. So one is we have a lot of screening is much better for breast cancer. And so we don't necessarily jump to saying, oh, you have to go remove your breasts, but more we want to really, really follow you with breast MRIs, which is shown through actually the University of Chicago with Dr. Olapati to be really effective identifying cancer at a really early stage. And also when about 2013, the Supreme Court actually overturned a really important genetic law that said Myriad doesn't have a sole right to testing for BRCA1 and BRCA2. So genetic testing now is really, really a lot less expensive than it was when I was working in 2004. It got as expensive as $7,000. And now you can do a out-of-pocket cost of $250, and you don't just get BRCA1 and 2, but you also get what we call panel testing. Panel testing allows you to do genetic testing for not just BRCA1 and 2, but lots of different genes at the same time, because we know that BRCA1 and 2 are not the only ones that can cause breast cancer. There's lots of different results that can come up. Genetic testing isn't as it's not black and white. It's not this is yes and this is no. You can have no mutation identified, but maybe you still have a high family history, and so maybe you're still at risk. And you can have a mutation that is identified, but maybe it's suddenly, and this is what this one's referring to, maybe it's suddenly a gene that we weren't expecting to find at all. And that happens a lot actually in my field. So your family history is suggesting breast cancer, but suddenly we identify a colon cancer gene in you. So that's something that you're going to want to know. And then we always have these variants of uncertain significance. Genetic testing, basically our technology is way ahead of what we know what to do with that technology sometimes. We all carry benign changes that are sometimes not meaningful at all. And so that is what sometimes we will find on these variants of uncertain significance. So what do? Once you identify a genetic change that may be putting you at higher risk for cancer, you have 3 options. You have increased surveillance. And then there's some chemoprevention drugs, such as tamoxifen, to reduce your risk for breast cancer. There's also, sometimes you can go on aspirin to reduce your risk for colon cancer. And then there's also preventative surgery, so removing organs before you get cancer. This isn't as highly accepted unless it's a really, really high risk of getting cancer. Some screening and surveillance. Regina already kind of went over this. It's really important, though, I wanted to point out, is that there's no real such thing as ovarian cancer screening. Transvaginal ultrasounds and CA-125s don't do a good job of identifying cancer at an early stage. Ovarian cancer, unfortunately, is found usually in stage 3, stage 4. So the standard of care is to recommend removing ovaries if you're at higher risk for ovarian cancer. So I just wanted to give, in case anybody has any questions or they're interested in genetic testing, this is my direct contact. I'm happy to take questions and always set up a visit. Thank you so much.
All right. Well, I would like to introduce our next speaker, Ms. Luz Chavez, and she is the lead outpatient dietitian in the Department of Supportive Oncology at University of Chicago Medicine. Welcome.
Okay, so I'm going to try to do my best to stay within the 15 minutes. This by no means covers everything, so I tried to cover at least some of the basic information for kind of the different stages of either treatment that you may be in, or if you're just interested in prevention. So in terms of how nutrition can actually help you, in terms of prevention, when you're at a healthy weight and physically active, this has been shown to help in the prevention of certain cancers. The American Cancer Society has a statistic saying that roughly about 18% of cancers can be decreased by being at a healthy weight and being physically active. I don't know how recent that percentage is, but at least it kind of gives you an idea how impactful nutrition can be. Now, during your treatments, it can actually help support your immune system. Now, the way that nutrition does this is by helping prevent malnutrition. And the way that it does this is by helping you maintain your muscle mass. Your muscles are incredibly important. It's tied to your immune system, but if you're malnourished, if you've been losing weight, if you're not eating well, this actually can lead to increased risk of infection. And then if you're also very weak from losing weight, this can actually lead to your treatments either being paused, stopped, and that includes for chemo and even radiation treatment if you aren't handling them well. Now, another way that nutrition can really be helpful, especially with medications, is it can really help manage your side effects a little bit better. So a little bit later, I'll get into specifics, some basics, but when you combine some nutrition tips along with like nausea medications, for example, it can help you feel a little bit better. Where you take one or the other by itself, they may not work as well. Now, when you're well nourished, the research has found that it actually helps improve your survival rate. And if you're feeling well and you're not as fatigued or malnourished, can help improve your quality of life, whether it's after your treatments or even during your treatments. So just to kind of give you some ideas as far as how you can, get to a healthy weight. These are some suggestions from the American Institute for Cancer Research, or I'll refer to them as the AICR. Walking can be very helpful for weight loss, so you don't have to think that you have to go out there and run a 5K or you have to go do like CrossFit or anything crazy strenuous. Just simply starting to walk and having the intention to, challenge your body by trying to increase the effort that you're putting towards it can help you lose weight. Now, what I mean by that is, if you're starting off by walking 10 minutes a day, if you've never done any exercise before, just having in mind that as you find that it starts to get a little bit easier as your body adapts, having the intention to go up by another 5 or 10 minutes and continuing to do so, because your body will adapt to certain situations, including exercise and diet. So if you're not challenging it, that's where you kind of run into those issues where your weight loss plateaus, where you're not losing weight. So always kind of keeping that in mind. Now, some other ways to lose weight is aerobic physical activity. So this would include more of like the running, a little bit more strenuous activities. But with that, what I want to know is making sure that, especially if you're in treatments or if you have any kind of heart conditions, making sure that you clear it with your physicians first to make sure that it's safe. Now, fibrous foods. This can also help you lose weight. Now, the way that it does that is it actually helps you feel full. If you're eating primarily a diet with simple carbohydrates, which an example would be like white pasta, white toast, those simple carbohydrates digest fast and you're going to be hungry very quickly. If you have whole grains, fruits and veggies, all those are going to help keep you full longer because they're full of fiber. And those foods actually go along with the Mediterranean style diet, which it doesn't have like specific rules in terms of kind of what you need to follow day by day, like some of these other diets, kind of like the keto diet, those other diets. It's more of a style of, not even a style. I'll say that it's more about the ingredients itself, which I really like because since I work with a lot of different patients from different cultural backgrounds, it's easy to implement the ingredients from this diet into different kind of cultural recipes. So that's why I really like this kind of Mediterranean type, eating pattern. Now, breastfeeding, if you've had a child, can also help you lose weight. The way that it does this is when you're breastfeeding, your calorie needs actually go up. So if you're watching what you're eating and only eating, a few more extra calories to kind of compensate for that breastfeeding, you'll find that it'll help you lose a little bit of weight during that time. Now, what causes the weight gain, especially here in the US? Our Western diet. Now, what I mean by that is, kind of the steak and potatoes, the fried foods, which kind of goes into the fast foods, which is next. Those kind of foods, when you pair it with increased screen time for adults or kids, and then sugary sweet beverages, that's what leads to the weight gain. Now, the AICR, to kind of go with the weight loss, they have some recommendations as far as cancer prevention. However, I just want to note that this is not only for cancer prevention, but if your symptoms are pretty mild during treatments, these are also recommendations that most oncology dietitians will make. And then even when you're in the survivorship phase, when you're done with treatments, these are the same recommendations that we will typically recommend. So they're honestly, they're applicable for anyone. Once again, be a healthy weight and be physically active. Your fibrous foods, have whole grains, veggies, fruits, beans, all those are going to help keep you full, but they have a lot of good nutrients and they're good for your colon and they help you have good poop so you're not straining. You also want to make sure that you limit the consumption of red and especially processed meat. Now, their recommendation in terms of red meat is making sure that it's lean red meat, but trying to stay below, they say like anywhere between 12 to 18 ounces. Now, for someone who is eating red meat daily, it's going to be a big adjustment. But for the most part, 12 ounces of red meat a week is still a pretty generous portion. Now, in terms of processed meats like hot dogs, bacon, those kinds of things, they recommend to try to avoid it altogether. Or if that's too hard to do, try to keep it to a minimum. So like on a monthly basis. Now, limiting the sugar sweetened drinks as well, because this leads to, weight gain. And then the weight gain is what, increases your risk for different cancers. Same thing with alcohol consumption, trying to limit that as well. For women, the recommendation, I believe, is 1 drink per day. And then for men, it's 2. Of course, if you can drink less than that, that's even better. Now, fast foods, it's the same situation as sugar sweetened beverages. You want to try to limit that as much as possible, avoid it if you can. And if not, try to keep it to like on a monthly basis. Once again, the breastfeeding can be preventative. And then one thing to note is that they do specify not to use supplements as a form of cancer prevention. And I do want to say that, there's so many supplements out there that are being pushed on the internet, and many of them don't have research to support them. And then they're also not even regulated. So what that means is that what is being put in the supplement may not necessarily be noted on the label because there isn't a regulating company behind it. Like the FDA is not looking into to see what's on the label is actually factual. So some tips for during your treatments. So during the treatments, and you'll notice kind of this repeating, small frequent meals. You want to eat in a pleasant environment, engaging in physical activity because this is actually going to increase your appetite. And then even protein shakes can be very helpful. Some patients say that drinking fluids is much easier than chewing food when you're not feeling well. Now, diarrhea, because this can be very common. And I'll just kind of skim through this. The general idea from the slide is essentially a pectin fiber. Pectin fiber helps bulk your stool. So this includes foods like bananas and applesauce, or it also includes benefiber, which is an over-the-counter supplement that's right next to the Metamucil, or Benetrol, which is banana flakes. Now for radiation-induced diarrhea specifically, I usually start with psyllium fiber. And if patients don't tolerate that, we may move back to the pectin fiber. And all this would be in conjunction with your medications as well. Nausea and vomiting, some examples of nutrition tips would be eating starchy foods like crackers and toast. If you like ginger, you can include ginger products. And then another one too is just avoiding very strong odorous foods, or not even being in the kitchen when you're cooking, because that can also kind of turn you off and just make the nausea worse. And then after treatment, your symptoms don't always go away right away. So this is where working with a dietitian can also be helpful, because she'll help you, or he will help you through the process of kind of slowly adding back in foods as your symptoms are kind of resolving. Your goals should be to get to a healthy weight after your treatments, making sure you're eating a good plant-based diet, the whole grains again, being active, limiting the processed meats, and then having some healthy fats. Not all fats are your enemy. Now I'll go through this real quick so I don't go over time, and we can always talk about this during the Q&A portion. Some questions that I always run into that I wanted to address is this sugar-free cancer. Not quite. So the reason I say not quite is because every cell in your body needs sugar in the form of glucose in order to run, essentially. Now, what does lead to an increased risk of cancer is consuming too much sugar that then leads to the weight gain. That is what kind of puts you at that higher risk of, different cancers and diseases. Keto diet, not a lot of research, to put it shortly. We typically don't recommend it because we don't have guidelines on how to implement it safely in most cancer types. So what we will recommend is more of that Mediterranean style diet. And then the last one is, should you eat organic foods only? There actually isn't a lot of evidence to support that only organic foods lower your cancer risk. What they typically look at are conventional fruits and veggies, and that we do know can lower your cancer risk. We also instead, with the combination of the fruits and veggies, it goes back to the previous recommendations. It's kind of about your lifestyle in general, being at a healthy weight and being active. And then here are some resources. The AICR is one that most oncology dietitians across the US always refer to. Usually pretty up to date and reliable. And then our Oncology Credentialing Association also really relies on their research and their recommendations. And then cancer.org can also be very helpful, and cancercare.org. This is where I usually kind of send my patients.
So with that, we will transition into our next speaker, who will be giving us more information about clinical trials and sort of demystifying clinical trials in general. So our speaker is Dr. Catherine Kernett. She's an assistant professor of obstetrics and gynecology at the University of Chicago Medical Center. And I am going to stop sharing my screen and allow her to share her screen so that she can give us more info about clinical trials. Welcome, Dr. Kernett.
All right. Well, thanks for the invitation to be here. I'm really excited. So I'm Katie Kernett. I'm one of the GYN oncologists at the University of Chicago, which means that I'm a doctor who takes care of women with gynecologic cancer. So cancers of the reproductive tract. Mostly. I do surgery and I do chemotherapy, and I take care of women kind of across their journey. But one of my personal research interests and clinical interests is in clinical trials and kind of the framework specifically for cancer and drug development. And I was very interested in those poll results, and I'm glad that most people have heard of clinical trials, but it sounds like we still have a lot of work to do, which is sort of what I know to be the case. So I'm going to give a very broad overview and kind of get into a little bit of the nuances with cancer clinical trials, and then talk about enrollment and things. But I'll put my information up for contacting me at the end if anyone has specific questions, or I really do love talking about this and trying to increase education and awareness. So please don't hesitate to reach out, even if we miss each other in the breakout room. So I'm going to start with a brief overview of clinical trials, kind of what it means. In general, the big picture is that clinical trials means that it's a research study where we are enrolling patients or including patients in these studies to test something. And in my case, it's related to cancer, but there are other clinical trials that exist. So what I'm going to do is go through what we call the phases of clinical trials. So before a drug goes out onto the market, before you can buy it in the pharmacy or before a doctor can prescribe it, there are a lot of steps that need to happen. There's a lot of, from when the drug is developed or discovered to when it's actually available, there are a lot of different, what we call phases of trials. And so I'm going to go through some of these phases because I think this is one of the most important things that gets lost when we're communicating with patients and with the community. So the next couple slides that I pulled from the American Cancer Society website. It's a wonderful resource. I'll put a few other resources up in a little bit, but this is cancer.org. So this first phase, I'm not going to spend a lot of time on. This is called phase 0. My guess is most of you haven't heard of this. These trials are pretty rare, but I'm putting it up there just for completeness. Phase 0 basically means that we are exploring if and how a new drug might work. So we enroll very few patients get included on this study. And the goal is to improve our understanding of the science. So in order for a drug to be able to be given to a person and be tested, it had to have already gone through a lot of rigorous things. So it had to be tested in cells and in cultures, had to be tested in mice and small animals. It had to be tested in primates. So there's a big amount that happened before it came to people. But once it gets to people, there's still a long journey. So this is basically just to make sure that what we think is happening with the science is actually happening with people. And so an example of this type would be having patients on this study who a few patients will take this medication and will do a sample of their tumor, like a biopsy or something before and after, and see if it changes. So it doesn't necessarily help women live longer or live better, but it gives us better understanding of what's going on. And I apologize. I tend to use the word women because I take care of women, but trials also apply to men and other settings too. So phase 1, this is a kind of more of something that probably a lot of you have heard of. This is phase 1 clinical trials. Is the treatment safe? So this is a small number, but not, it's still enough that we can study it. So we say anywhere from about 6 to teens, 20s, small number, but good handful of patients who all get different doses of the drugs. And the goal here is to understand the side effects or the quote unquote safety of it and the appropriate dosing of the drug. So we know before we even give it to a single person, we know approximately what dose to give. We know approximately what the side effects are. But until we test it in a variety of people, we don't really know if that's going to be true or in how many people we're going to see that, or is the dose like the difference between 5 milligrams and 10 milligrams? Does that make a difference in terms of how well people do with the drug in terms of side effects? So the example here is that we enroll, let's say 9 patients, 3 get 5 milligrams, 3 get 10 milligrams, 3 get 15 milligrams. And then we track what are the side effects? What is the best dose? Do the women who got 15 milligrams, is it too toxic and they actually need 10? So it's a kind of a test to see what the right dose is. And then that will be the dose. This is important because that's the dose that's then used most of the time forevermore. So phase 2, this obviously comes after phase 1. Does the treatment work? Okay, so this is a little bit bigger study. So anywhere from 10s, teens, 20s, up to maybe low 100s. The goal is to determine whether this specific drug works in some specific subset of patients. So the first study, the phase 1, can be a little bit more broad. A lot of times we say cancer patients, or we say cancer patients with gynecologic cancers, or cancer patients with leukemia. Like, it's fairly broad. But with this one, we start honing in. So we might say, this is for women with ovarian cancer specifically. And what we're doing is seeing if this drug will work in this specific type of cancer at the dose that we already determined from phase 1, from that earlier clinical trial. And so in this one, 50 women might enroll, and we might give them all 10 milligrams of this new drug. And then we look at how they do. Does their cancer shrink at month 0, 2, 4, 6? And we compare that to what we think is the average rate that cancer would shrink. And then that gives us an idea, is this drug likely to work? So it's not very honed in, but it's giving us kind of more data to understand, is this drug going to work for these patients? Now, phase 3 is probably the study design or the study type that most people have heard about. And this is really important. So this study question is the drug that we are testing, is it better than what we already have? Okay, so that's different than phase 2, which is, does it maybe work just in general? This is it better? Because we're not going to make a new drug. We're not going to go through all of the money it takes to make a new drug and push it through and make sure it's safe if it's not better than what we're already doing. Because what we're already doing works and is safe, and we know more about it. So in order to bring something new to the table, it has to be better in some way, whether it works better or safer, something has to be better. So this is usually like hundreds of thousands. These are big studies. We can't do them alone. We can't do them at one place. University of Chicago can't do it by itself. They have to include people across the country, sometimes across the world. And again, it's to determine whether it's better than what we already have. So in this study, and this is an important difference, a lot of times a portion of the patients will get the new drug and a portion will get the old drug. And so some women aren't getting the new treatment, but in order to make it a really fair assessment, we have to compare it to something. So in these big phase 3 trials, it's where we have the most information. It's where we have the most hope that drug is going to work, but half or a third or some number of women are not going to get the new treatment because we have to safely be able to compare them. And so with this is the final phase. If this trial finishes, and if we have data that say, yes, this new drug ABC is better than what we're already doing, then they go to the Food and Drug Administration or the FDA, and they say, this is our case. And then the Food and Drug Administration says, okay, we think that is reasonable and safe, and we're going to approve it. And once a drug is approved, it means that insurance companies are supposed to cover it for patients who meet those criteria. And so any drug that you can get in from a doctor or anything that's FDA regulated, like ibuprofen, anything like that, all went through clinical trials. That's all drugs, no matter what they're for. If they are regulated by the FDA, they went through these studies. Phase 4 is after it's already approved. It's kind of the what else do we need to know? So this is a lot of people. It's basically trying to see, does it work in the real world? So clinical trials are very strict. We're making sure that people are kind of safely selected, but we don't know, that's a very sterile, very kind of regimented environment. Let's say Mrs. J wants to take a month off of treatment to go to her daughter's wedding. That's kind of real world practice. And so we need to know, does that work? Does the drug still work when we're doing it the way that we're going to do it in the community? And they sort of regulate that after drugs are approved to make sure no new problems arise, because sometimes they do. Okay, I can come back to this slide, but this is just a general slide of things that I've over the years collected for patients. I think these are wonderful resources. Most of them are not gynecologic specific, but they're American Cancer Society. There's a Society for Gynecologic Oncology, number 2. There's the NIH, clinicaltrials.gov. These all have kind of resources that I think are accessible to patients to varying degrees to talk more about clinical trials for people interested. I want to kind of end by talking about who enrolls on clinical trials and why this is important. And this is part of what I'm really passionate about, because clinical trials change the way cancer is treated. Any drug that we give to cancer patients goes through a clinical trial. They only represent the women who were included in that trial. So if you do a trial in ovarian cancer and you only include women from, Omaha, Nebraska, does it really apply to my patients who I take care of in Chicago? And, that's a very specific example, but we have to make sure that when we do these studies, that they represent the people who are going to be getting the drug after it's approved. So this is a big one. I'm going to be talking about gynecologic cancer because that's what I know about. But when I've done research into other cancer types, this is fairly representative. And unfortunately, we know that there are very disproportionate enrollment in trials. And so in phase 1, those early phase clinical trials for gynecologic oncology, this study looked at between 1985 and 2018 and found that the enrollment was really disproportionately not representative of who gets these cancers. And so they found that, quote, no phase 1 study met the expected enrollment for Black participants. So they knew what the proportion of ovarian cancer patients who are Black are, and they knew for endometrial and cervical cancer, and they looked at those studies and they found that we were not meeting those same proportions. And that's a problem. So that's one study of many that have shown that we do a really bad job enrolling a lot of subsets of patients. And this is a big statement that came out a couple of years ago from a lot of our cancer organizations, some of the big ones, including the National Cancer Institute. And they went through a bunch of different things, but one of them was clinical trials. And in here, stringent criteria for participation in cancer clinical trials and common procedures for providing trial information have been barriers to enrollment. And this is true for, they talk about for racial and ethnic minorities, rural residents, older patients, patients with low SES, limited English, low health literacy, and comorbidities. You can imagine for my patients who meet multiple of these, it becomes harder and harder to get onto a clinical trial. So how do we improve enrollment? We need to be better because I need to make sure that the drugs that go through are actually going to work for my patients. So as a field, as a society, we're trying to improve, but it's also my job as a doctor to think about how I'm personally going to improve. How can we all make this better to improve enrollment? So some ideas that have been thrown around in the literature and in the community and in big forums where we talk about this is doing what we're doing now, just trying to increase education about clinical trials because there's a lot of unknowns about it. For me, I found it's really important to acknowledge and address the historical context. There's a lot of problems with racism in medicine, with research, with all of the things that have gotten us here, Nuremberg and Tuskegee and all of the forced sterilization. And we need to acknowledge those and address them in order to improve trust. Reconsider enrollment criteria. So if I exclude all women who have high blood pressure, that isn't going to apply to my patients. We have to find ways to safely include those patients. Talk to patient advocates, people who know about these cancers personally from themselves or family, and talk with members of the community who may not know about cancer, but know about the community and know about what the needs are and what we can do. And the final thing, and this is what I found from a lot of advocates, is offer enrollment. The number one reason women don't enroll on trials is because they weren't offered it. And so if the doctor sitting there makes some biased assessment saying, well, this patient isn't going to go on a trial and doesn't offer it, that's a disservice. And so in my mind, it's important that myself and everyone offers trials to everyone. And that's a push. But I also think we need to empower patients and tell them this is an option and this may be a good option for you. And if you go to your doctor and say, are there any clinical trials? It may push the envelope that they would say, oh, yeah, I guess I should talk about it. So we just need to do a better job of offering it to everyone. I wanted to end on something optimistic, and there's a lot of ongoing problems, and this paper is very recent. It's not super optimistic, but in my mind, the whole take home here for me is this orange means like private trials. They're still not very good. But when you look at National Cancer Institute, so federally funded trials compared to proportions of women. So they looked at federally funded trials and enrollment of Black patients and the national proportions for that cancer type. For things like colorectal, we're starting to close the gap. So I think we are in some cases doing a better job. In many cases, we're not. And there's a lot of work to do. But I think that more awareness, I really do think we can be more kind of equitable in offering trials. So I'm going to stop there. It was a lot of information that I could talk forever about, but if you all have questions or want to talk more, either now or in the future, this is my contact information. Email me. I'm happy to chat more. I love trials. I love educating about trials. So please don't hesitate to reach out. Thanks again.
Thank
Thank
you
you.
so much, Dr. Kernan. Again, another speaker with just a wealth of information. So thank you so much.
So in closing remarks, it takes all stakeholders, community-based organization, corporation, local businesses, funders, and I say that in caps, learning institution like the University of Chicago, Medicine, their institution, just to name a few, to close the health disparity gap and to create a whole and thriving society. We hope that you gain some new insights from our speakers today. Early screening saves lives. Clinical trials are important for discovering new treatments as well as detect and diagnose diseases. Nutrition does matter. What you eat before, during, and after a diagnosis can impact your recovery as well as your survivorship. As I shared in one of the chat rooms, I am a survivor myself and overcomer from my religious standpoint, and so is my mom. And finally, genetic testing plays a vital role in determining the risk of developing certain disease and help people to make informed decisions about managing their health care. We want to list, and I'm so pleased that all of our presenters have provided some community resources, and these are some additional ones. Some are duplicated under each category. For screening services, we can email this out to everyone who had signed up. Or you can do a screenshot of this.
We'll also post it on our website as well.
Yeah, thank you. That's a great idea. Green and Matt, they offer genetic testing. All of Us research program is also another genetic testing, free genetic testings for people of color. We have clinical trials that was listed earlier from our presenters, and nutrition program, which is near and dear to my heart as well. Cooking for Health. This is a lifestyle nutrition program at which we offer here at Advocates for Community Wellness. There's also plant-based nutrition movement about healthy eating. And there is a forum that's coming up earlier part of November, gathering around the table, Food Talk for Cancer. Let's stay connected. This is our information about our two hosting organization, Advocates for Community Wellness and the University of Chicago Comprehensive Cancer Center. And also, this concludes our session. We appreciate your time, and our time is up, and we thank you for yours. Share what you know. Knowledge is power when you use it. Thank you.